may I request Professor Abduz Zaher sir and as chairperson, sir, you please come. Professor Uddin Mondol, Professor Uddin Mondol, Professor Mohammad Shahabuddin, Dr. Harunur Rashid Bhuiyan, and Dr. Tamzeed, Dr. Sadi.
Hi Bharat, can you hear us? Let me introduce our session panel member. First of all, I can introduce Secretary General, our Professor Mir Jamaluddin. He is the Director of National Institute of Cardiovascular Disease. He is the Secretary General of Bangladesh State of Cardiovascular Intervention. And he will welcome you. And as well as I introduce Dr. Azfar Bhuiyan. He is the moderator for this today's session. And this session is chaired by Professor Abduz Khan and also Professor Tamzeed Ahmed, Professor Shahabuddin, and Professor Dr. Roisuddin Mondol as well, and Dr. Harun Rashid Bhuiyan as well. And Dr. Sadi Bhai is our senior colleagues, and he's a very, very experienced operator in Bangladesh. So it's my privilege to hand over the mic to our moderator, Dr. Azfar Bhuiyan. He will continue the session. Before your presentation, just give short introduction given by our Secretary General.
Thank you. Because we are a bit delay, not only a bit, almost full time we have passed with the previous topics and previous session. So we are extremely sorry. We shall call now Dr. Bharat Purohit, who is the senior consultant in Care Hospital, Hyderabad. Please show your case.
Thank you everyone. Good morning to all of you from India and Hyderabad especially. And I am really honored that you invited me to your such an august gathering where all stalwarts were there. So of course, a little bit delay, but that's okay. We all know in this kind of conferences when important topics are discussed, sometimes it gets delayed and it gets prolonged so that we can gain and share knowledge from all the experts in the country, in the world. So I have Dr. Vinoth with me, who will be helping me, and Dr. Dhananjay also will be helping me, and our senior technician, Mr. Suresh, and Sister Vijaya is there to help me. So with this, I will start this case. I'll ask Dr. Vinoth to introduce about the case. Can you just show me the case presentation? Yeah.
Good morning to all of you. This is a 68 years old male known case of systemic hypertension and Parkinson's disease. He was suffering from chest pain since 1 month. Almost he is not able to walk even 10 feet. And with dyspnea on exertion, that too worsening since 15 days.
You are not hearing. Hello?
Okay, I'll just say, Mike is there with me, so that's the problem. So this is a 68-year-old gentleman, hypertension, Parkinson's with significant angina. He is unable, even though he is a Parkinson with limited activity, whenever he goes for a little walk to washroom or he eats something and then goes out, he gets angina. And despite being wheelchair bound, he still had so much of angina. So we decided we will go ahead and do an angiography. Can you just show the angiogram for this patient? So this is the ECG, shows some ST depression in V2, V3, V4. Just go to the next. Can you show? Yes. No, just come to the live. So you can see this patient has a very tight ostial LAD, and just before diagonal, there is across the diagonal, there is a tight lesion. And you can see a lot of calcium in the LAD from proximal to mid part. The circumflex also has significant calcium, but except for little mild disease in the proximal and mid part, we did not see much of a disease in the proximal part. The RCA was a non-dominant artery. So I'm not showing those pictures in the interest of time. So in the meantime, when he was there on the table, he was having little angina. So I just went ahead and did the POBA of the mid LAD lesion, which was tight. Can you, yeah, just previous shot.
Dr. Bharat, in your last slide, we have seen that left PDA, LPDA is also significantly
Yes,
diseased.
LPDA is also significantly diseased.
That's right.
Next slide. Yeah, next. Yeah, you can see here, just before the contrast come, you can see the significant calcium in the proximal and mid part of the LED. Can you show the angiogram?
No, we are not seeing at the moment.
Yeah.
Show us.
Can you see this now?
Yes. Yeah.
You can see the significant calcium there in the proximal and mid part. So he was having angina. So just to save time, I just did a POBA of that lesion. Go to the next. You can see the wire is crossed, and then we took a 2 millimeter balloon to dilate it. Now we are going to do an OCT and see how the calcium looks. So can you just show me on my hand here in the catheter? Can you focus on the camera here? Okay, zoom. You can see the OCT catheter. That can you
Yes.
see it?
Yes.
We are just introducing the catheter to take the pre-OCT run. You know, nowadays when we do OCT, we follow the principle of MLD max. We first assess the morphology, the length, the diameter, and then we decide what to do. So this is the pre.
It is dragonfly catheter.
Yes, sir. Yes, sir. This is a dragonfly optis catheter from the Abbott. Just pull it. Just leave the wire. Come forward. You had done that optimization. Come forward. One forward. One forward. So we have crossed, gone to the distal LED, and now we will take the first run here. Give me 20 cc. There's a contrast. So any suggestion, how do we approach this case? Because we have decided that we will go from across the left main to LED, and then we will see how the lesion looks, and then we'll see whether there is any pinching of the circumflex, and based on that we'll decide. So we are planning a provisional stenting without going for a dedicated two stent strategy. So I'll just yeah, once you tell me, I'll inject. Okay. Yeah. Yeah.
You give the dye by manual injection.
Yeah, we give manually because it's a 7 French catheter, so should not be a problem. Just take it. Just take this out now from my research. Nikalo. Take it. Clear? Take this. Ready? How is it? No, we did a dissection flap.
Yes, yes, dissection we are seeing at 6 o'clock, 4 o'clock.
You can see there is a deep calcium here. It's not a very superficial calcium. And there's a tight lesion with a lot of dissection. I think that is mainly because we dilated that area with the balloon. And you can see there's a
calcification, thick calcification.
Yes, thick calcium is seen. So it is almost more than 180-degree calcium, and it is also
180 dB, yes.
thickness is also almost 0.7. So if
And-
you go by that algorithm which they follow, what is the depth, what is the and what is the length? So I think it is definitely coming more than 4. Come from that side. Come from that side. So how does the Austrial LED look? Yeah. Okay, that's okay. We'll do it next time. No, it's okay. See, we were more focused on that. How much is the length of calcium and all that. So I think we can. So because of the significant calcium,
Yes.
what do you think? Should we go with a plain simple NC balloon, or you think we should take a little more calcium modifying device like a IVL balloon to clear it?
Initially, we like to use high pressure balloon, NC balloon, and we see the result. If there is no dog-boning effect on the high pressure balloon, then we can go with stand. Otherwise, we shall have to debulk the calcium, maybe OCT, maybe Rota or IVL. As because more,
Yes.
you can use IVL.
The only issue with Rota here is because the calcium a little more deeper.
Yes.
So even if we go with the Rota, we may not be able to do much to this calcium which is there, and that's why I thought we will use a IVL here. And the reason I wanted to avoid multiple OCT is because of the creatinine, which is around 1.3. So
Yes.
I think I decided to go straight away with a IVL and see how the post IVL looks, whether we are able to fracture it properly or not, and then decide. So what is the diameter of this?
Before IVL, you do not want to enlarge the dia further with a balloon?
Yeah, that we will do. We will take a 2.5 balloon and dilate it, and then we can take a IVL balloon and do it.
That's all right. IVL balloon will enter.
Dr. Purohit.
Yes, sir.
Okay, fine. Just here our Dr. Gambhir is here. He would like to make any comment.
Yes, sir.
Yeah, good morning, Dr. Purohit. This is Dr. Gambhir sitting in the
Good morning, sir.
audience. Good morning. Well, great case. I've been seeing the case from the beginning. I think the choice of debulking is an issue in this patient. You have possibly pre-decided about IVL, so that's fair enough. But at the same time, I feel that even deep calcification, because since you have to do a long segment here, right from the ostium onto the mid-LED, even
Yes.
of
Yes, sir.
starting with 1.75 and upsizing it to 2.15 if the vessel is 3.5, you can do. But since for simplicity, I feel that most people now fall upon IVL. But I'll show you today in the afternoon the case where deep calcification, IVL failed. And finally, I got rid of the calcification and expanded fully the stent with 2.15 bar. I upsized the bar to 2.15 and was ready to go further. I think basically what we feel is that people are a little scared of using Rota and are very scared of not using the adequate size of the purr. So, but I think for the sake of interest of time, IVL may be a good option here.
Yeah, I fully agree to what you say, sir. The main problem is when we use little bigger size burr, most of the operators are a little bit hesitant to use a burr more than 1.5 or 1.75. So, and now with the advent of IVL, the things have become a little more simpler, especially in deeper calcium, and we just tend to go with that. But I fully agree. If IVL would not have been there, definitely I would have thought of Rota in this patient and gone and went ahead with that. But before Rota, I would have definitely tried with NC balloon, a 3 mm NC balloon, to see whether I am able to do it.
Okay, I think you should go ahead.
So we have dilated with a 2.5 mm balloon in the meantime, and now we are going to do the calcium modification with the help of a IVL balloon.
Wait,
We are taking a 3 IVL balloon.
IVL balloon, what is the dia length?
3 into 10.
3 into 10.
Yes, 312, sorry, 312.
12.
Because it comes in only one length, 12 mm. And diameter can vary.
It is only 2.512 or 2.7512 for
312.
It is the only single size, but
Yes, sir.
multiple diameter, right?
Yes, sir.
Yes. Multiple dia.
But if the patient has little nodules and all this thing, then it becomes little tricky using a rota and all these things. What is your experience with nodules, Professor Gambhir? Because you have been doing a lot of rota, I know.
Regarding nodule, rather than IVL, I think rota is superior.
Yeah, I fully agree with
Running this.
well, if you see a nodule,
Yes, sir.
the rota is the best strategy.
Yes,
And in
yes,
fact,
sir.
we recently did a case where it was undetected. It was nothing was visible on an angiogram, and there was a 80% or 85% stenosis at the origin of circumflex. And we thought it's a 5. So we passed a 2
Don't
minute.
remove it. After deflating, don't remove.
Step down the balloon to 1, it
Negative.
would not go. But with some difficulty and manipulation,
Now, 4 times.
down.
Yeah.
Then 2.5 millimeter balloon would not go. Then I thought that we should do a IVUS. We did a IVUS and we found a nodule projecting from the carinal side into the lumen of the circumflex. So we lost no time and took a 1.75 bar and did ablation of this nodule, and then everything walked on smoothly. So I think what we learned is that nodules get easily ablated if you use a proper size rota. In this patient, like 1.75 did the job because the vessel was about 3. But if it had been a big vessel, you can upsize your bar and you can get away. So in nutshell, rota is the best choice for a nodule. But be careful that wire bias may sometimes happen, and if the wire bias happens, then you may be burying on the opposite side rather than on the side of the nodule.
Any experience with orbital, sir? With regards to nodule?
Not as yet.
This toy is not available in Bangladesh.
Not even in India also.
Not yet.
But they say it's a good tool for eccentric calciums and all these things. Where many a time because of guide wire bias, you may tend to miss with rota.
If we miss with rota, then we shall do rotatripsy.
Yeah.
And if
It's coming up in a,
then you do rotatripsy rota.
because many a time these IVL balloons are very bulky and they will just not track beyond with the dense calcium. So we have to combine both rota as well as IVL to be able to achieve a good result in them.
Yes, sir. This is also a modality is
Just
rotatripsy.
opposite, huh? Just opposite. Yes. Connect it. Yeah, done.
Dr. Purohit, this is Dr. Tamzeed from Dhaka.
Yes,
Would
sir.
you consider any wiring the diagonal here?
Right now we are going with only a ballooning of the LED. Once I think of putting a stand, because too many wires and all these things may complicate. So that's why, just to keep it simple, I'm just going with the ballooning. Once I complete that, because I'm not doing any balloon or dilatation of the circumflex or ostium of the circumflex or the left main. So should not be a problem for me when I go with a wire into the circumflex after completing the ballooning with the IVL.
Thank you.
So is that a IVL balloon
Request
or
any,
is it a
any other comment
ordinary
from
balloon?
our chairperson?
Now we are now taking the IVL balloon. Can you just show me that balloon and you can show the shockwave
Balloon
device
is
there?
not crossing.
Yes, this is the shockwave machine which will deliver the shocks. And we are going to deliver 80 pulses. And the balloon I'm just trying to introduce.
After I will going to do OCT again.
Yes, after IVL, I'll do OCT once again.
Thank you.
So you have two reasons. You will first go to the distal one and then do the proximal. What
Yes,
is-
sir. Yes, sir.
Distal one first and then proximal.
First distal, then ostial.
As because it's
You can see it is difficult for me to push this balloon down. Yeah, now I think I'm there.
it has crossed.
Yes, now it has crossed. Despite pre-dilatation, still it was facing so much of resistance. Chalo, not required. Now you can. Are we ready with the pulses? Indiflator is Vinoth, you don't go up to 4. Yeah. Don't pull. Yeah, go to 4. So we dilate up to 4. There's a nominal, and then we start giving the pulses. Go to 6. 6 is the nominal inflation for this balloons. The whole idea is to oppose the balloon to the wall so that the energy can go through the artery properly. So we just go with a nominal, just little under dilated. 4, it will go up to 4. Yeah. So you can see this. With this, we press and the energy is delivered. Generally, it's a pretty safe device, but very occasionally, patient may have little VT. I had one case where patient developed VT when we are giving it. So otherwise, it's pretty safe. Very occasional case report of perforation, but we have not experienced any of those. Any experience with complication with this device, like balloon rupture and all this thing? Anybody else? Yeah, 3rd. Yeah, go to 4.
Our experience with IVL is preliminary, meaning that in Bangladesh, probably not more than 50 cases has been done yet. And that is why our experience with complication is till now, no complication.
Yeah, that's what even the registries, disrupt registries have said, but occasional case reports we keep hearing. So we have given up to 30 pulses right now. So I'm just coming little proximally now. Ready?
Micro dissection or small dissection.
Yeah. 4.
The perforations have been reported. I'll show you. Perforations have been reported, but they're very.
The idea of deflating the balloon during IVL is basically to dissipate the heat which is generated, and as well same time you can allow the perfusion to happen once again, because in peripheral also we generally deflate.
Dr. Purohit, one small question here, and I would like you to comment on that for the sake of the audience.
Yes, sir.
The question is that, when you inflate the balloon of IVL, if your lesion is very highly calcified, as we interpreted in this case, you often see a waste.
Yes, sir.
If the calcium is extended from the superficial down into the deep side, and that is where that's why you picked up the IVL. Now you often see a waste, and that gives you an idea that this lesion would not possibly have got cracked with the conventional high pressure balloon. Now, in your case, both the sides, I did not see any waste at all at even 4 atmosphere. So in hindsight, do you think that this lesion could have been treated without even the IVL?
Maybe you're right, sir. But when we start the case in a patient who is 70-year-old with Parkinson's and calcium, we and with we just didn't want to take any chance. We just wanted to complete the lady. If anything happens,
no, nothing would happen. If you take an ordinary balloon and go to high pressure, nothing would happen.
deflate.
The point that I'm trying to make is that sometimes we go with a preconceived philosophy or strategy in our mind that, okay, in this case, we have to do a IVL. So this is a good test to find out. You put an ordinary balloon, 4, 5, 6 atmosphere, and if, as you also said in the beginning, there is no waste on the balloon, there is no dog boning. Well, go ahead and put in a stent. You can even upsize the balloon to 3.5 if the vessel allows you. But going straight away with the IVL balloon, which even at 4 atmosphere did not show any waste. So I think the future few minutes will tell us what have you got.
Yes. No,
Dr.
many
Zahir,
times we go directly and put a stent also, and we have seen after putting a stent, we see there is a lot of under expansion and malopposition in these kind of vessels. And then subsequently post stent expansion, again we have to use IVL in these cases. I did it in 2 cases where I did with a simple OPN balloon dilatation. And then subsequently we did a OCT, and OCT showed 2-3 areas where there was malopposition, and then we took a IVL again in those selective areas, and then did a post dilatation after IVL to get a report. So it's okay.
Dr. Purohit, have you used this IVL after stenting?
Yes, sir. 2
Okay,
cases
post stenting.
Yeah, it
post
is
stent.
described in Disrupt 2 trial. One arm was only post-stenting 16 or 18 patients. Post-stenting IVL where the stent was under-expanded, and they put a IVL, it's very safe. And I feel that's a very good indication of IVL. When sometimes you make a wrong judgment, you think that the stent would expand, but unfortunately it did not. And then you can put an IVL and can get the vessel fully expanded.
Yeah, that's another way of looking at going ahead with the procedure also.
Dr. Purohit, proximally you have placed the balloon in left main involving.
Little bit of left main, yes, sir. Yeah. So we are going to go to the last pulse here,
Yes.
because we saw a little waste when we are doing this rather than the distal part. So I think this is what.
So how many cycles you have given in the distal and how many in the proximal region?
I gave 30 cycle in distal, sir. 3 cycles and rest 5 here.
So one
Because as you rightly said, I did not see much of waste happening in the distal part. So when I came proximally, you see in the initial stage, there was a little bit of waste there. So that's why I concentrated here more. So it's done. So we have completed. So I'll take a post run once again and see how it looks. So give me the OCT catheter now. Yeah, this is over. Take this out. Yeah. OCT का दे दो. Where is the OCT catheter?
Dr. Purohit, have you ever faced any complication during IVL?
As I said, I had 2 patients where we had a VT. Other than that, yes, 1 patient when I did first time, there was a balloon rupture. Other than that, I did not say. The reason I think the balloon rupture could have happened because it was a lot of calcium. I did not do adequate pre-dilatation before taking the IVL. I had just dilated with the 2 and then took a balloon. So tried to force the balloon down. Maybe that might have caused some damage. And when IVL started, it ruptured. So from that time onward, I generally do a little more dilatation before I take the balloon. So that was the initial time when we were starting to use IVL.
No, I feel that rupture is really not to be counted as a complication because it's a calcium spicule which must have punctured your balloon, and it's a part
Maybe
of
that yes, maybe.
the procedure. Number 2 is, well, if you even dilate before putting a IVL balloon with a balloon of ordinary balloon, a rupture can still take place because
Yes, sir.
at most you're going to put a 2 millimeter balloon. That is not going to take away the spurs which are
Is
present.
okay? Abhinav?
Rupture can still take place. And it's not a major complication. It is only a waste of the company's 1 balloon.
Ready? Give me a 20 cc balloon. Give me the balloon. 26 syringe. No?
And
No.
Dr. Gambhir, can you tell us regarding the second time use of this IBL balloon, meaning that
Milliliter saline.
2 patient, 3 patient, I shall do in the same day, and all of them will require 1 or 2 pulses, meaning that 10, 10, 10. Can I use it
Ready?
using Cydex for the second?
I can't answer this question because we have never used second time. So all our balloons get exhausted in the first patient itself.
I want to tell in a different setting,
You
meaning
want me to pull what?
that in the same way,
Yeah,
we are
I
doing.
Undergo?
Understood your question that if some pulses are still left and you can on the same day, can you use the same balloon in another
Yes,
patient?
yes.
What do you want to pull?
I don't know. We have never used it and the company does not recommend that. So I can't really answer this question.
Thank you, sir.
Actually, it's not ethically correct, but for financial reasons, we have to do it sometimes.
Okay, no?
Yeah, the other patient can be used. If you're left with some pulses, if you are doing LED and at the same time you're doing RCA, you can put the balloon into the RCA. Good. Provided some pulses are left. But in another patient, I have no idea.
Hmm. Why it is not coming? No, no. Give me the number.
You're not getting clearance of the blood from the.
I think my guide is little outside. Just
Yeah.
check.
Put some diet 2 to 3 cc first from the guide and clear the blood from the guide also. Because in the initial part, the blood is going into the artery. You know, the guide contains 7 ml of blood.
Yeah. Yeah, that should be okay. Ready?
Moderator.
Just go back. Now you can see those fractures.
Yes.
Multiple cracks you can see. If you see in the microfractures and all this thing, you can see there.
Plaques there, yeah. Very nice.
But if you look at, for example, 10 to 12
From 10 o'clock to 6 o'clock, you can see this
calcium
again.
to the
And
main-
now here at 3 o'clock position, you can see the fractures which is there. Come to the distal LED first.
the fractures are only in the superficial calcium.
Yes, sir.
But
Yeah, let us go to the previous one, which was showing the distal.
at the 11 o'clock position, I think there is also deeper calcium.
Pardon?
Yes.
At the 11 o'clock position, I think there is also deeper calcium.
Yeah.
Right.
What is
So you
the-
can see that calcium there.
What is the vessel size media to media?
Media to media is 2.7 is the size.
I think you are taking advantage.
0.7.
Many a times, recently one paper came from Renu Virmani, which showed that even though you may not be able to see this calcium rupture in the OCT, there will be microfractures, which now you can see this fracture on the 3 o'clock you can see,
Yes.
as well as up 12 o'clock also you can see.
3 o'clock, it looks like nodule.
Yes. No, not nodule. Now you just go back, go back. Yeah, there you can see there, just next. Yes, at 9 o'clock you can see there is. Go next frame. Yeah, there it is. Here now again you can see. So give me what is the length of the lesion? Can you just tell me? From where to where? Yes, not required.
So Purohit, I just draw your attention, actually, we
33.
have to
Just
move
give me
on
that wire shot.
because I
338 you give me the.
won't give information, small information for you.
Yes,
If
sir.
you can't complete your procedure, please continue your procedure. We will come back to again with you. And
Yes, sir.
now, 11 o'clock. Now we are planning to move within 5 minutes for the next session. So I think you can try to proceed.
Yes,
your-
I'll complete in the meantime the stand deployment and do the post standing
You can,
OCT and come back to you again.
you can continue 10 minutes
10
more.
minutes, 10 minutes.
more. Then
Just
if
give me the 338.
then you can go for recorded and see.
338 you give me.
We can come back to you on the screen. Okay.
So we are taking a 3 into 38 Giants Alpine, and then we'll see. Show me that wire shot now. Previous wire shot. First shot. Next. Next. Yeah. Run it. Yeah. Give me 338 now. Give me the stent.
How much are you going into the left main with this stent?
So midway up to.
And what was the diameter or the size of the left main?
Left man is 4, sir.
So you would expand this 3 to 4 in the left main. Am I right?
Yes, sir. Yes, sir. Just check. Just give me a shot. Okay, wait. 1 second. Flush. Auto flush kar do? Yes. Now give me that shot. I think we are absolutely rightly placed. Yeah. Okay. Just give me a shot. Come to PA caudal.
Landing,
Test.
distal
fluoro.
landing zone is 2.75.
Go up to the PA cranial now. Inject. Yeah, go. Just go up to nominal.
Do you want to cover the entire left main, Dr.
No,
Purohit?
sir. No.
Yes, 50% of the left main, meaning that keeping 8 millimeter proximal to the left circumflex.
Yes, sir.
Okay.
Deflate.
Nominal pressure, you have inflated it
Yes, sir.
as because distally dia is less.
You see, I have still not put any wire into the circumflex, but ideally
Ideally,
you can
one
always do
even in the circumflex.
because the angle looks pretty good, and I did not expect too much of trouble. Even if it is needed, I can still go ahead into the circ and wire it.
If there is good angle or circumflex origin is almost disease free, in that
Yes.
case, take the chance.
So you are confident.
Yeah, he is confident
You are
that
confident not
circumflex
to
will-
lose your sarc, right?
Yeah, I don't think I'll be losing it. You can see looks pretty good, circ, and the LED looks pretty good. The lesion has covered. I'll just do a little bit pot here. Just give me a four balloon, short balloon. First, give me a 3 NC balloon.
Take a AP caudal or a LA caudal to show us the origin of the circumflex.
Yeah, I will do that, sir. Just give me a PA caudal.
You are using giant alpine, Purohit?
See, sir.
Yes,
Looks
giant
absolutely clean.
338.
Yes, sir. Giants Alpine we have taken.
Do you have giant Sierra?
Giant Sierra we don't have, sir. Because of NPPA price control, the company has still not launched it in India.
in India.
So
Not yet also come in Bangladesh.
how much length of the left main is covered by the stent, Dr.
I
Purohit?
think around 5 to 6 millimeter.
So you do for pot you may need a smaller 6 millimeter balloon, 4 into 6. Yeah.
Probably 6 millimeters they have.
How biggest,
Eight
longest,
नहीं है.
Yeah.
8 नहीं है.
because the size of the balloon per pot, you know.
Length कितना है?
Don't get 6.
8 I want. 4, 8. Just for pot. Acha, this is 3. No, come to this is NC3. Yeah, go to pre-cranial. So this is a 3 millimeter balloon just for the post dilatation.
Post dilatation.
Go. Fourteen, 16, 18.
312.
Yes, sir. This is a 312.
12 NC balloon.
We have gone up to 18, and I think we have
18.
adequately dilated it. Come, leave the flat.
We hope you will wrap up within 5 minutes.
Dilate.
5 minutes?
Hopefully, sir.
Yes,
Okay,
it will be
okay, sure.
finished.
Deflate. Give me a 4, 4, 8 or 4, 6, whatever is there. Dilate. Fourteen, 16, 18, 20. Deflate. Come to PA view. Yes. Yeah. थोड़ा caudal कम करो. Make it little less caudal or little less, still more, less caudal. Yes, now it's okay. So this is a 4 into 8. Maybe will be little bit into the ostial of LED.
4 into 8.
Yeah, because 6 is not there in the self. So I'm taking a 8 and hopefully should not be a problem.
Yes, yes. The proximal LM is a bit wider, so I think there will be no problem.
1 second. 30 frame nahi hai. 30 rakho na. Because the obese patient, right? I'm not able to see properly. 1 second. Don't inject.
Have you any plan to rewire, recross the LCX and to
Dilate.
open up the start?
There are two schools of thought here, sir. Some people say, yes, we will post dilate and we'll do a little bit of small dilatation of the studs to remove them from the ostium of the circ. And some say maybe it's not required. So I will see how the circ ostium looks and then take a call.
How
Because-
Sarcastic behaves.
6, 8.
Go by
Different.
EBC, European Bifurcation Club.
हाँ, sarcastic come.
They, in all provisional stenting, first thing is that they recommend with force that all side branches must be wired. That's one. Number two is they say that at the end of the procedure, you should first
थोड़ा delete करो ना उधर से.
recross the side branch balloon, open up the, remove the struts which are coming in front of the side branch, do a kissing balloon, gentle kissing balloon, and then do a repot. So this is the step-by-step approach from the EBC.
Deflect.
I agree that contrary to this, there is also a view that you unnecessarily don't have to open up the struts which are coming in front of the side branch. Because in one study which appeared almost about 6 years ago in JAC intervention, that there's no difference in MACE at 1 year whether you do a kissing balloon after provisional stenting or you don't do a kissing balloon. The MACE remains the same. So I think you very rightly said,
Oh.
look at the
Leo caudal. Caudal.
only thing is that you therefore have given up the idea of opening up this LPDA or the circumflex distal. There's a significant
Yes.
disease.
Yes, this is the disease.
As because dominant
Because
vessel,
he is,
critical
the
lesion.
problem is he is a very old, very sedentary person. And significant angina, I thought is maybe because of this LED only. So once we clear it, he should be all right. If he still continues to have despite this, then maybe we'll think about that. Because there's a lot of disease in the whole circ there. So in future, if they progress, then again he may need some more intervention. Just give me the OCT now. We'll just take a final shot. So the circ looks pretty clean here. The ostium doesn't look much pinched despite the stent across the left main. So we'll see the final OCT and see how it looks. Yeah.
Just as at proximal LED, just distal to the bifurcation, I need, that needs some post dilatation.
We'll
And-
see in the OCT also, sir. How does it look? Come to PA cranial. Na? Come forward. Is it okay? Saline there, though. First, give me saline. Ready? No, it's okay. We will be able to get it in this time. Yeah. That's okay.
In the
Just osteum. Right.
in the
Saline.
proximal part, probably there are few red.
I'll just see it again, sir, with the catheter pull little bit more. The catheter did not take the ostium properly. Ready? Yeah. Yeah. Yeah, looks okay. Looks okay.
Actually, that proximal part of the left main is not free from blood. So why it is not coming it is not giving a good image.
Yes, now.
And you can, there
Give me
is
20.
section, there is no malposition there.
Bas.
Just now.
I think there is a little bit of some few struts in the left main are still not opposed. So I'll just take a 4.5 and see.
Yes. At the proximal part of the stent.
Yes. Yeah, there it is.
I'd like you to
This is
measure.
the circ branch.
Okay.
This is the final angio shot, and we'll show you the OCT run also, which looks pretty good. Just show the OCT run. So we, after getting that OCT, we post dilated again that area with 4.5. And this is how the OCT looks. Just run it. This is the proximal LED, and we are now coming back into the left main. You can see all the studs are well opposed. There is no under expansion. Now the circ is coming. You can see all the studs are nicely opposed, and you don't see much of studs across the circ origin also. So now let us, can you show the 3D view? Yeah. You can see the circ origin. And the 3D also looks, all the studs well opposed, nothing much. And MLD, how much was the final MLD left main? 13.59 is the lumen area. So looks good. So thank you for once again coming back and seeing the final result. Thanks for giving us the opportunity.
Wonderful final results. Thank you very much, Dr. Purohit, for a beautiful and excellent, well-demonstrated case. And with that, we'll move forward to our next session on chip and CPU intervention.
Thank you, Dr. Purohit.
Yes, sir.
For your brilliant case.
Sure,
Hopefully
sir.
meet once again with you physically in Bangladesh. You are cordially invited to Bangladesh. Now the session will be wrapped up by our senior most professor, Professor of Interventional Cardiology, Professor Abduz Zaher, sir. May I request, sir?
Thank you, everyone. Just give me the 4.5.
Professor Mir Jamaluddin. It is a brilliant demonstration for our country, and especially in our younger people, interventionists who are doing learning intervention, this advanced intervention in our country. And I thank Professor Mir Jamaluddin that he has started the OCT, IVAS, plus rotablation in NICBT, so that many people will be able to learn it and discuss it and practice it in our private and government hospitals. And I thank you very much, and thank for the authority for inviting me to share this session. I close this session. Thank you very much.
Thank you, Dr. Bharat Purohit, for your brilliant case, and we'll come back after finishing your to see the final result of your case.